In this video, I'm going to comment on a post in my X account, formerly Twitter. I posted 3 images for apparently look similar cavitating lung disease, and I asked for each image the same question: to which condition does this HRT appearance correspond? And the multiple choice: bronchiectasis, or cavitating pulmonary metastasis, or pulmonary Langerhans cell histiocytosis. Let's start with this image. Here we have mix of nodules and cavitating nodules. Some of the nodules are not cavitating, like here as well, and the others are cavitating. Our clue is the distribution. Here we have single image. Actually, in cases of pulmonary Langerhans cell histiocytosis, there is predominance for upper lobes. But in this image, we can assess the axial distribution, not the craniocaudal distribution. The axial distribution tells us that these cavitating nodules are present in centrilobular location. So here we will exclude the metastasis, the cavitating metastasis. Is it bronchiectasis? Not a bronchiectasis, because they are not communicating. You cannot follow the nodules to another parent bronchus dilated, or they are not branching as well. And we will comment more about the bronchiectasis at its image. So this is PLCH diagnosis. Based on the axial distribution, here we have based nodules cavitating on the pleura. This is the random distribution of cavitating nodules. The randomly distributed nodules with or without cavitation will highlight the metastasis as a differential diagnosis. And PLCH is not, because it's centrilobular location of the nodules or cavitations. But here, our differential diagnosis is the randomly distributed nodules with cavitation. What we have here in the multiple choice is the metastasis. So metastasis is our choice. Here, the last image provided in the post, we see that the cystic bronchiectasis is one of the pitfalls. It's not a true cavitating lung disease, but it's a pitfall because of its appearance. The other types of bronchiectasis are well differentiated and can be diagnosed easily in the cylindrical type and the varicose type, as you can follow the continuity and branching pattern of the bronchiectasis. But here in cystic bronchiectasis, sometimes it's hard to follow this, but we have a nice sign which is called bunch of grapes along the bronchovascular bundle. You can see the cystic changes along the bronchovascular bundle in a bunch of grapes sign, with spared other areas of the lung spared from bronchiectasis. And serial images and video of a case, this will help to detect this continuity with the parent bronchi. Plus, this patient have already dilated bronchi here, mucus filled, giving the bronchocele appearance. Actually, this patient is allergic bronchopulmonary aspergillosis. You can use this algorithm for cavitating lung disease after exclusion of the pitfall of cystic bronchiectasis by checking the distribution. If the cavitating nodules are predominantly at the periphery of the lung, so this is diagnostic for septic embolism. If the distribution is random, seeing nodules along the pleura in a major fissure, minor fissure, or along the pleural surface, the differential diagnosis, mainly here metastasis, dermatosis with cholangitis, formerly Wagner's dermatosis, is a differential. The other 2 entities are very rare: the light chain deposition disease and benign metastasizing leiomyoma of the uterus. If the distribution craniocaudally is upper lobar predominant, check the nodules. The nodules or the ground glass opacity in upper lobar predilection, the differential diagnosis. If it is ground glass opacity parahilar with cystic changes, so this is diagnostic for pneumocystis jirovecii pneumonia. If the nodules are there in the upper lobes and they are centrilobular in location, some of them are cavitating, as in our case. So this is agnostic for pulmonary Langerhans cell histiocytosis. The differential here is something very rare, which is the rheumatoid arthritis, because the microbiotic nodules, necrobiotic nodules of rheumatoid arthritis is the least of the pulmonary manifestations of rheumatoid arthritis. The main presentation is the interstitial lung disease, including UIP, NSIP, organizing pneumonia, but presenting with the necrobiotic nodules is rare. And what is helpful for diagnosis of that, presence of calcification of the nodules, if calcified or not. Thanks for your attention.